What is diabetes? Type 1 diabetes is a chronic condition in which the pancreas produces little to no insulin. Genetics and some viruses may contribute. Treatment includes managing blood sugar levels by taking insulin alongside diet and lifestyle changes. Type 2 diabetes is a chronic condition in which your body resists the effects of insulin or does not produce enough insulin. Genetics and environmental factors may contribute. Losing weight, eating right, and exercising can help control, however, medication may be needed. Diabetes emerged as a leading health problem in the United States with 21 million people currently affected. 1.5 Americans are diagnosed with diabetes every year. As of 2017, 8.8% of Americans were without any type of health insurance, leaving 2 million diabetics paying out for treatment out of pocket.
Do you know anyone diagnosed with diabetes?
Yes, as a matter of fact, my husband was diagnosed a couple of years back. He's a physician, and even as a physician, he had let his weight get out of control, and as a result, developed diabetes. And we were fortunate enough to be able to get some information about diet, and we changed the way we eat as a family. And he's lost 50 pounds, and his blood sugar is absolutely normal right now. So we feel like that we intervened at a time before he got complications.
I'm raised here in Tuscaloosa.
Do you know anyone diagnosed with diabetes?
Yes, several of my family members are.
Which ones?
I have two brothers, and my mother had diabetes.
Are they currently being treated or following their treatment?
Yes, my mother is deceased, but my two brothers, they're following their...
What did their doctor prescribe them to help with their diabetes?
One of them take the pills, and the other one is, give himself shots every day.
Shots of insulin?
Yes.
Can your brothers afford to pay treatment or for their insulin with costs being raised lately?
Yes, they can. They can afford it. One of my brothers work for the federal government, so they pretty much, and the other one works for the state, so they're pretty.
Would you say that they're middle class or high class?
Middle class.
Middle class. Does insurance actually help cover these costs?
Yes.
I currently live in Greensboro, Alabama.
And do you know anyone diagnosed with diabetes?
I do. My father-in-law and one of my son's preschool teachers.
Do you know if your father-in-law is currently being treated for his diabetes?
He is. I believe he is type 2, and he goes to his doctor regularly. And I'm not sure if he has to take insulin shots, but I do know he has a lot of pill form medication. And the teacher I know actually has to wear an insulin pump.
Does your father-in-law have insurance that's covering those pills that he has to take for his diabetes?
Yes. Currently with the job he has, they have very good insurance, so he's...
When were you diagnosed with diabetes?
5 years ago.
5 years ago?
Yes.
Are you type 1 or type 2 diabetic?
I am type 2.
Are you following treatment or taking any insulin or anything for your diabetes?
I don't have to take insulin, but I take medication.
Medication? What does your medication help you with?
I'm not too sure exactly what that does, but
Has your doctor ever explained to you what your medication's
I don't think
for?
so.
When were you diagnosed with diabetes?
So when I was officially diagnosed, I was 11, but diabetes really runs in our family quite a bit, and so I have two brothers, and my parents kind of figured that one out of the three of us was going to have it, and I'm the lucky one. I won the lottery, so they were watching for it for a long time. And so when I was 8, I started having low blood sugars, and both of my parents are hypoglycemic, so they're not diabetic, but they have lows. So they were kind of wondering whether it was just going to be a situation like them or whether it was going to be the full-blown diabetes. So they started taking me to the doctor, I think, when I was about 9, and they said, no, she's not diabetic, it's not time yet. So we probably caught it as early as we could, because we started looking at 9 and taking me to the doctor probably every 6 months. And then finally when I was 11, they're like, okay, yeah, she's definitely diabetic. So we caught it so early that early on, all I was taking was 24-hour insulin, and I wasn't even taking fast acting, which is kind of weird. Like when I would get low, it's like an excuse to eat sugary things. And so
So now do you have a pump?
Yes. Yeah. So I got a pump I was a junior in high school, so that was 2008, I think.
Stigma. Irving Goffman defines a stigma as an attribute that is deeply discrediting. It is imposed on the individual by other people, but can still have a negative effect on the self-concept of the person being stigmatized. According to Daniel Reedpath, medical sociologist, the fear of being stigmatized is enough to stop someone from going to the doctor. For example, someone who is heavily overweight will avoid going to the doctor due to the fear of being stigmatized, and often those who are overweight have an increased risk of having diabetes. Doctor-patient interactions. Talcott Parsons defined the doctor-patient relationship as the doctor having the dominant role due to their expertise and the patient holding a subordinate position. People with diabetes fall into mutual participation model because it has to do with the management of chronic disease where the patient is expected to make lifestyle changes and follow a regimen of medications to help control their diabetes. Z. Lepowski's labeling theory. Individual strategies vary from passive cooperation to positive action to get well from fear of getting diagnosed. Someone of lower socioeconomic status will be more passive in dealing with doctors, while someone who is of higher status will be more of an active patient. People of lower socioeconomic status often feel a lower sense of control when handling their health problems.
And do you believe that there's a stigma surrounding diabetes?
I don't think so. I mean, there's so many people who have it. I think everybody has a family member or a friend who has diabetes. And I think there's so much of a social support that goes with it that I don't think there is a stigma.
I feel like people in general have a fear, and that some doctors have gotten a reputation of not having a very good bedside manner, that they may not have their patients in their best interest, and that you're just a number in line. So I definitely can see why there's a stigma and people not really jumping out there to go.
And do you believe that there's a stigma surrounding diabetes specifically?
I believe certain people who don't know much about diabetes would probably assume some negative things about people if they said they had diabetes, just assuming that they were just poor hygiene or, poor lifestyle, or they come from a lower income that can't afford the best type of food, this, that, and the other, or they're lazy, don't have good work ethic, that kind of thing.
Do they frequent the doctor's office and are sure to be honest with their doctor about how they've been feeling?
Oh, yes. And, with our family history, the doctors pretty much, stay on them pretty, much regularly, make sure their medications are being taken and make sure they have everything they need.
So how has your experience at the doctor's changed since you've had your family history of diabetes?
With me having the family history of diabetes, my doctor is very adamant with me keeping up with the proper weight and blood work.
How often do you frequent the doctors to take care of your diabetes?
Probably about once a year.
Once a year? Okay.
I don't like to take needles. I hate having a needle stuck in me.
Okay, so when I was first diagnosed, I still remember my first doctor. Her name was Dr. Tapiador, and she was this very short woman who had very tiny hands, but very cold, very strong hands, because they always have to, touch you and, make sure everything's good, and, as an 11-year-old girl, it was, super weird and whatever. But she was probably the most middle ground doctor I've ever had, to where... And of course, I was 11 at the time, but I remember her talking to me saying it was equal parts encouragement and scolding, to where if my blood sugars weren't right, she's like, okay, you really have to get on this because you don't want to have a kidney transplant when you're 30. I mean, she's bringing this stuff up when I'm 16. And then, but it was also okay, here are the things you can do to really help. You need to stop doing this, but you can do this and it'll really help. So she was definitely very middle ground. And I had her until I was 18. She was my, pediatric endocrinologist. And then when I graduated from her, I only had a few months with the other doctor because I turned 18 in November. I left for college that following August. So I only had a few months with this other doctor. Hated her, absolutely hated her, because she was all parts scolding, guilt tripping, just making you feel like a really terrible person for everything you did. And so she would look at my numbers, and she was always really mad that she always said I didn't check enough. She was like, you're not checking enough times during the day. So that was one thing that she would always get on to me about. And then, you know, she would just get on me for general control. She was looking at my A1C and saying, you know, you should be a lot lower than this. And the weird thing is that my grandmother's also diabetic, but she's type 2, but she's insulin dependent. And so she was like, well, your grandmother has a lower A1C than you should be ashamed of that. And just like all these, she was using these weird tactics. I don't know if it was because I was 18 and she thought I was just like really irresponsible or anything like that. She didn't know me at all. And so she didn't know the type of person, the very type A, like salutatorian of my high school kind of thing. Like she didn't pick up on any of that. So I was fine leaving her. And it was a practice with 2 endocrinologists and a dietitian, diabetes educator. And the first endocrinologist I had was wonderful. She was really sweet. Her son was diabetic, so she knew like the ins and outs of it, even if she wasn't, which has a much bigger difference than people realize, because you can have a lot of endocrinologists that are really focused on the hormone side of things, and they're doing diabetes because they have to, but they're not diabetic. And so they don't really get it, and so they don't really get how hard it is to just think about it constantly. I mean, because your body's unpredictable, and there are so many factors that can affect your blood sugars that people don't. You can get stressed and it's going to skyrocket, or you can get stressed and it'll go low, and sometimes when you exercise it goes up, and sometimes when you exercise it goes down. Like, it's just really hard to predict. And so she was really understanding. She was very like, okay, I know your A1C is not where we want it to be, but we can do this. Okay, I know you're stressed. I know you're in college. I know it's not easy. So she was really understanding and very like mom-like. But then she left the practice and had to go to the other endocrinologist. And I knew it was a bad sign when I would go in the waiting room and there was no one in there. And it was just me. And I thought, why are there not many people here? And what I figured out was that he was just very dismissive. He didn't really care. He would come in for about 5 minutes. I would wait for an hour when no one else was there. And then he'd come in for about 5 minutes, talk briefly about everything, would hardly look at my blood sugar. She'd be like, we need to do better. And that was pretty much it. And then I would spend half an hour with the diabetes educator, who at that point thought I needed another lesson on how to count carbs, which I had been doing since I was 11. And so, I don't know, she took a really weird approach, and they wanted me to see a psychologist and a therapist and all these other things. I'm like, I'm here to see the endocrinologist. Can I just see him? Because that's why I came here. So eventually, the last straw was when I went for an appointment, waited for an hour. There's no one in there. They're playing these weird, like, healthy meal videos on the TV of meals that no one's ever gonna eat because it's disgusting. And I didn't even get to see him. I only went to the diabetes educator. And I'm like, she's not an endocrinologist. And she's the one, she was trying to configure my rates, and she was trying to do all these things that the endocrinologist should be doing. And I was like, I came here to see the doctor. My insurance is paying for me to see the doctor. Can I please see the person who went through medical school? That's kind of what I would like. And so after that, and they actually told me no. They're like, he's not here today. It's just the diabetes educator. I was like, well, that's not who I came to see. So I ended up leaving that practice and then changing over to the endocrinologist here in Tuscaloosa, which is Dr. DeBell, which probably 90% of diabetics in Tuscaloosa go see. He's great because he's diabetic. The diabetes educator is diabetic. They're both diabetic and on pumps. So to have people like that in the office that can really relate to what you're going through and how hard it can be and that kind of thing makes all the difference. And obviously, like, not every endocrinologist is going to be able to be diabetic.
Stereotypical diabetic. Oftentimes, the standard stereotype of someone with diabetes is an overweight white male, but the true statistics show that type 2 diabetes affects 11.5% of non-Hispanic blacks and 9% of Hispanics. African Americans and Hispanics have the highest rates of poverty, making up 27.4% and 26.6% of the 46 million Americans that are currently in poverty. The risk of type 2 diabetes increases with age due to decrease in exercise and increase in weight. However, type 2 diabetes is increasing among children and young adults. From 2002 to 2012, the rate of newly diagnosed American adolescents with type 2 diabetes increased by 4.8%. Illness behavior. Socioeconomic status influences which symptoms are perceived as warranting medical care, as well as the frequency of doctor visits. Dr. Earl Coos conducted a study in Regionville which focused on people's attitudes towards sickness and health and created 3 classes of people. Class 1 were the most successful and the most likely to recognize symptoms that needed medical attention. Class 2 was the middle class. And Class 3 was the lowest class and were indifferent towards majority of symptoms. The barriers that separate these classes are cost, fear, relative need, and group expectations about the symptoms.
And what do you believe to be the stereotypical diabetic?
From personal experience, probably one who takes a lot of medications. From professional experience, I think we see a lot of complications from diabetes. So I think as a physician, as a pathologist, in my head the stereotype is an uncontrolled diabetic with a lot of health problems. But I'm not sure that's the real story that's out there in society.
What do you believe to be the stereotypical diabetic in today's society?
I feel like if you're not educated on knowing the fact there are 2 different types, your automatic assumption would be somebody maybe male in their 50s, definitely overweight, not very active, poor lifestyle. But for those who are a little bit more educated, they know the differences and their assumptions may be a little bit different.
Do you believe that your father-in-law or your son's teacher fit into that stereotype of this stereotypical diabetic?
Definitely. My father-in-law used to have the typical dad belly, and he was a smoker. He didn't eat very well, even though he lived on farmland, didn't eat a lot of vegetables and all that good stuff. And the teacher I know, same way, she's a very busy mom, 3 children, you eat on the go with practices and that kind of thing. So I know she was probably slightly overweight, but she has type 1 insulin pump, so I guess that's really not too much of a factor since she's got type 1.
Wow, that's a very hard question, because when I think of a person being a diabetic, I think of someone that's extremely overweight and someone that just don't take care of themselves.
Do you believe that your family members fit into the stereotype?
No, because neither one of them are overweight and they pretty much take good care of themselves.
What the stereotypic diabetic is from all the questions I get from other people. So the main thing you get is that, gosh, there's all these terms that people throw around that just aren't terms. And so I wish people would stop using them, and I wish doctors would stop using them, because it's not a thing. So there's no such thing as a pre-diabetic. You're diabetic or you're not. There's no pre-diabetic. Like, that was just something that most of my doctors that I've ever had have agreed on. They're like, you can't be pre-diabetic. You can be like, they would rather use the term borderline than pre-diabetic, because just because you're pre-diabetic doesn't mean you're actually going to have diabetes. It just means that you're on the line, you need to watch it. I hate that term. So then you've got type 1 and type 2. And with type 2, usually, not all the time, but usually they'll start out with diet and exercise and trying to control it that way. They may add some oral medication in there to try and control it that way. So the main thing I get, especially from like the older people at church kind of thing, is, they find out you're diabetic. First of all, everyone thinks the pump is a pager, which 10 years ago that may have been okay. Everyone thinks it's a pager, which is fine. Like, my dad still has to use a pager at work because it's in a high security plant. Like, it's a whole thing. But most people think it's a pager. And this was especially true when I was in like middle school, high school. Mm-hmm. So much so, here's a crazy story. So there was a girl that was my age that had been diabetic since she was 4, I think. So she had a lot more experience with it than I had. So we were like diabetes buddies, and like we would go check her blood sugars at the same time, and it was a whole. She played soccer with me, and it was just a whole thing. So we had different classes though, and there was the science teacher in middle school. He was just terrible. We called him Blowfish. He looked like a blowfish. Like, he had these really bulging eyes and like whatever. He drove a Mazda Miata that he could barely fit in. Like, it was a whole thing. So we didn't like him anyway. He didn't like us either. He was one of those teachers that hates kids. Like, I think he was teaching because he just couldn't do anything else. And so she was taking a test, and her pump went off, like a little alarm to let her know. I think it might have been a no delivery or like a low reservoir or something like that. He thought it was a pager. He thought she was receiving answers from someone who was paging her answers to a test. So he came over, asked her about it. She tried to explain that it was her pump, but he was one of those that, like, he just automatically thought it was an excuse, whatever. Not super familiar with diabetes. Took the pump, because he thought it was a pager, didn't know it was connected to her, took the pump, ended up ripping it out, ripped the site out, because he didn't realize, like, it was whole thing. He obviously got fired. Don't know what happened to him. But it was just one of those things to where it can get to the extreme to where people just think you're lying about. The main problem is trying to explain to people who have no experience with it, or the only experience they've seen is someone with type 2, and they're like, oh, so why can't they think you're a failure for having to be on insulin? Because they're like, oh, you couldn't control it with diet and exercise. And so then I'm a very snarky person, and I don't like people telling me I'm wrong about anything, so it's hard for me to, like, control myself anyway. But I have to be like, okay, actually, okay, here's what's happening. And it's like, no, can't control it with diet and exercise because that's not an option for me. And they're like, oh, why not? And I'm like, let me tell you about type 1 diabetes and, like, how it works. So you have to talk to them and be like, I've had this since I was 11. This is not something I can have any control over. This is much more genetically based than it is, like, lifestyle based. And these are the people I love who actually do have experience with type 1. And so they'll see your pump. And this has happened to me so many times. I've had, like, a mom see my pump. And they're like, oh, are you diabetic? And some people might think that, oh, that's a weird thing to ask somebody. But it's like a little community. And, like, the people, especially with the people with type 1, because you're all in this little club that you didn't ask to be in and that you'd rather not be in. And they get it. And they're like, how's your A1C? And, you know, are having issues with anything? And then I've had a lot of instances where moms have asked me for, like, advice, for especially if their kids are diabetic. Like, well, okay, what did you do in this situation? Did you like this pump better? Did you like this pump better? Who's your doctor?
Looks like to be an average diabetic.
Yeah. Like, is it someone who's, like, overweight? Is it a man, woman?
Gosh, I don't think that really matters.
No?
I don't.
Do you think anybody can get diabetes?
Yes, yes.
And then from a medical standpoint, what do you believe to be the most common gender and race for diabetes?
I think it's pretty much across the board, male, female, black, white. Probably in the South, though, probably there's a slight increase in the African American population affected, but that's just my opinion. I don't know about.
Do you believe that that could be from their lower socioeconomic status?
Yeah, I think a lot of it's dietary, and I think certainly socioeconomic status plays a big role.
Kind of have a fear of there being something wrong, and the whole lineup of testing and procedures and that kind of thing can be daunting, and plus the financial part may be a struggle. So I feel like they don't always speak up.
I haven't really, but that's probably only because I have good insurance, and I'm lucky enough to have always had insurance. I've never had to go without insurance. But I also know what insulin costs when you don't have insurance, because I've had issues where I go to the pharmacy and there's an insurance issue, and, you know, like, they give you the option of paying out of pocket. No, there's no way. There's no way that is sustainable to do that. So if you don't have insurance, I don't know what you would do as a diabetic, because it's a very expensive disease. Because whether you're on shots or whether you're on a pump, you've got all these supplies you have to do. Like, if you're on a pump, you have to have reservoirs, you have to have sets, you have to get alcohol swabs all the time because you have to make sure it's clean. You have to get sticky stuff to make sure it stays in. If you're on shots, you have to get the pens, and a lot of times you're on 2 different types of insulin when you do that. So it's not just one type, it's both types. And then you have to get the needles, and you have to get, it's just, there's so many things you have to worry about. And it's expensive. If you don't, even with insurance. We built that when we first got married and we weren't making a whole lot of money. We had to build that into our budget, like a diabetes budget. We had to put that in there. Like, here's the cost of insulin every month. Here's the cost of test strips every month. Here's the cost of everything. We built that in because we knew that was just part of what we were going to have to pay. So much so that now they do these, so certain companies will do these accounts, I don't remember what they're called, but you can, like, use money pre-tax to put in like a medical account, and they give you a separate debit card for that, and you can use that money just for medical stuff, and you don't get taxed on it or whatever. So we did that. We calculated. I'm a very expensive person when it comes to medical costs. So we calculated just like a rough estimate of how much we were going to spend, because it's significant enough to where it's, when we don't have to pay taxes on it, it makes a difference. And we ended up putting about $1,000 on there, and that was a conservative estimate. That's with insurance. So that's copays, and it's copays when you go to the doctor, when you go to the pharmacy, when you go to the podiatrist, because you have to watch out for your feet. And it's when, it's just all these different things you have to take account for. And like, I just got the CGM, that continuous glucose monitor, and the sensors for that are incredibly expensive, which is a great thing to have, but maybe you can't afford that. The less you can afford, the more terrible your control is going to be, because if you can afford all the extra things that can help your control, that's fine, go ahead and do it. But the people that can't are going to end up having bad control. Then they may be embarrassed to go to their doctor because they have bad control, like I was, because I didn't want to get scolded when I got there. So you push back your appointments and you forget your meter and all these different things. And eventually you're going to end up dying earlier because your control sucks. So yeah, it makes a difference. So it hasn't made a difference for me because I'm lucky enough to have insurance. But I can see how it would for the people who don't. That's why you see those little signs on the side of the road that's like, cash for test strips. And that's the thing. People are asking some people to get extra with their insurance so that other people can buy them at a lesser price than if they went just and paid out of pocket.
Life chances. According to Weber, the components of lifestyle are life choices and life chances. Life chances refer to the probability of acquiring a lifestyle, which depend on finances, status, rights, and relationships that support the lifestyle. De Hauttot and Field's 1984 French study showed that the lower socioeconomic classes viewed health largely as a means to an end as work, while people with higher socioeconomic statuses regarded health as an end of itself, as vitality and enjoyment. Someone's diet as a part of a healthy lifestyle is largely based on life chances.
You talked about food. What type of food is readily available in your area? Is it fresh groceries, or is a lot of stuff prepackaged and processed?
We do have a lot of farmland, and we have a farmer's market to get fresh produce, but the farmer's market is only open a couple of months out of the year, and we do have local grocery stores, but sometimes the fresh produce isn't the highest quality. And so a lot of fried foods at the local restaurants are served, and probably most people go with the fast food and the not so healthy options.
Where are you from?
Franklin, Massachusetts.
And do you guys have a lot of fresh fruits and vegetables available there?
Yes.
Yes. Do you think that your diet's high in sugar and fats and all that, and that adds to your diabetes?
No.
No?
No.
So since I'm type 1, can't control it completely by diet, but I have learned over the years what foods I need to avoid. Because here's the thing, is that some foods can affect people more than it can affect others. Every body is different. So what works for one person is not necessarily going to work for the other. My thing is I can't have regular soda. I can't do it. I will immediately skyrocket. It will take me forever to come back down. I just can't. I can't have regular soda, because it just sets me off for the entire day and I can't get back on track. I have a big sweet tooth though, so my doctors have been really good over the years with saying, listen, it's okay to have carbs. And it's kind of one of those things, I have a professor that says you can do whatever you want as long as it makes sense. Had a doctor who was like, you can have whatever you want, but you have to take, and you have to make sure that it's reasonably controllable.
Do you think it made a difference, like when you were younger, do you think it made a difference that like your parents were like really receptive to that and like could get you something other than like donuts to eat for breakfast or like didn't?
Yeah. So yes, of course, when you're first diagnosed, your first real doctor's appointment after getting diagnosed, it's like an all-day affair because you have all these different people to see. And one of the main people you see is the dietitian, and they teach you how to count carbs and, fist-size apple is going to be this many grams and that kind of thing. And so after that, my parents were always at that lesson too. And so we would the main thing we started doing was measuring things. And so it wasn't just pouring a bowl of cereal anymore. It was pouring it into a measuring cup first, so you know exactly how many grams of carbs there were. Or it was, used to drink a lot of orange juice. My dad's a big orange juice person, and had to kind of dial that back a little bit. So instead of having this huge glass of orange juice in the morning, it was like these little jelly jars of orange juice.
Consequences and why people wait. Susan Gore said that the timing of the detection of diseases such as diabetes, heart disease, and cancer is determined by factors outside the disease process itself, social and psychological factors that shape the individual's response to the often subtle bodily changes. Low-income African Americans are less likely to seek preventative care. Not being taken seriously when visiting health professionals leads to discouragement from seeking care. This can be contrasted with Mexican Americans having the lowest rates of overall utilization of health services.
What does your typical day look like when dealing with your diabetes? Do you find yourself getting shaky or anything?
Not very often.
Okay.
I don't think I feel shaky very often. A little bit sometimes. I think when I maybe get nervous or have to do a task or something, I might start shaking a little bit, but not very
And
often.
in your field, how common is it to see the dire consequences of long-standing untreated diabetes?
Well, as pathologists, we really don't see anything other than the dire long-term consequences. The well-controlled patient, we don't see the specimens, but we do see the diabetic legs, and we see a fair number of our autopsy cases who are also affected by long-term effects of diabetes.
On average, how many specimens a week do you receive from long-standing untreated diabetes?
On average, I'll say about 4. Because usually when we get amputations of toes and legs, we automatically assume that it's from untreated diabetes.
Do you believe that the number of amputations is because of the lower socioeconomic status of some people around here?
Absolutely, because with the number of specimens that we receive on a daily basis, it shows that people don't find going to the doctor as a necessity.
Do you believe that lower socioeconomic status people don't go to the doctor because they don't feel like it or don't have the time, or because they can't afford to?
I would say both. And I say that because, with the cost of insurance now, they just feel like it's not a need to have it. And then as far as like the symptoms that they have, they'll just brush it off and just feel like it's just nothing. And also, with my family being of middle to higher socioeconomic status, and working in the medical field, we know what symptoms require medical attention.
Dire effects of diabetes. Even though someone does not qualify for Medicaid, it is possible to still not make enough to afford good private insurance. Diabetes has treatments to minimize the effects, but if someone does not have access to a doctor or the means to pay for medication, it can quickly become out of control. Due to increasing cost of treatment, diabetes has become the 7th leading cause of death in the United States. Gangrene. It is a common consequence of untreated diabetes. This is localized death and decomposition of the bodily tissue stemming from smaller injuries that someone with diabetes cannot always fully recover from. Once gangrene sets in, there's only so much a doctor can do for a patient.
My name is Angela. I work for DCH. I work in the pathology department. The position I hold is the lab assistant. The lab assistant job consists of various different tasks. Upon my arrival, I have to go to 3 different departments to pick up specimens. Those departments are endoscopy, which, where they do the GI specimens, and colonoscopies. The other department is same-day surgery, and the last department is OR. After I get those specimens, I bring them back to the lab. I accession them, meaning that I put them in the computer. They're given an accession number. After they're given the number, I give them to the prosector. The prosector is the pathology assistant. He then dictates the specimen. and we take representative sections of the specimen, and then they're put in the proper solution to be cut by the histologist.
I'm a histotechnologist, and following the pathology assistants grossing in the surgical specimens, they are processed through a range of chemicals on a processor machine. And then once they're done, we embed the tissues in little cassettes of paraffin wax, and then we put them on a microtome. And from here, we cut very thin sections of the surgical specimen to get them on a slide so it can be stained for a pathologist to view under microscope.
When someone's diagnosed with gangrene from untreated diabetes, what's usually the protocol for that? How do you start with taking care of the gangrene?
From a surgical point of view, I think it usually starts as a diabetic ulcer. And then I think there's a lot of antibiotic treatment, a lot of local debridement. I think there's a lot of intervention trying to restore function to that limb. And on the pathology side, we usually only see the tail end of that when the ulcer becomes chronic and untreatable. And the only effective treatment is going to be amputation at that point.
And do you think that that's something that most people can afford to get it amputated?
The amputation is probably not the one that costs so much, but the long-term treatment, the preventive care is going to cost more. For instance, special shoes, special socks for foot ulcers. I don't know if insurance covers all of that. So I think by the time things get well established in the poorer communities, I think there's not a lot of options left.
Conclusion. There is a 26% increase in the cost of diabetes from 2012 to 2017 due to increased number of cases and increase in cost per person, as the price of insulin doubled during this time. For a diabetic with no health coverage, little community support, fear of stigma, low life chances, and low socioeconomic status, cost can be a large deterrent for seeking preventative care and proper medical treatment.